Okay, good evening, everybody. My name is Mira Halman-Ostrov. It is my pleasure to welcome you to tonight's Grand Rounds from JOWMA. We are lucky enough to have Dr. Ksenia Aaron coordinate this talk. The talk is called When a Medical Urgency Becomes a Surgical Emergency. It is our first surgery Grand Rounds, and I'm very excited to be the moderator. This is a very informative talk, both for primary care doctors as well as anybody else who is interested in the surgical field of medicine. Our first speaker is Dr. Tova Isseroff. Dr. Tova Isseroff is a board-certified otolaryngologist currently practicing in NYU Langone, Long Island, which is for us, those of us who remember it as Winthrop University Hospital. She's originally from Brooklyn. She received her medical degree from the Albert Einstein College of Medicine in 2009 and completed her residency in ENT and head and neck surgery at the New York Eye and Ear Infirmary in 2014. She then completed her fellowship in laryngology and voice disorders at Mount Sinai Hospital in 2015, and soon thereafter settled in the idyllic community of West Hempstead on Long Island, where she still resides. She divides her time between her bustling practice in Mineola, Long Island, and spends time at home with her well-intending horticulturalistic, husband and three very energetic brunette children. Without further ado, Dr. Tova Isseroff.
Let me just find the proper screen to share. And okay, thank you so much for asking me to be a part of this Grand Rounds. Just 1 second, since I'm really not so amazing with Zoom, I don't want my little picture screen to block how I can see my slides. So anyway, tonight, the topic that I'm going to talk about is when shortness of breath is a surgical emergency. I don't think this needs any additional introduction. Overview of the talk will be a definition and what an evaluation entails, different types of surgical airways, and then some clinical scenarios. So I know that we have a mixed audience, so I'm going to try to be basic enough for people who aren't familiar with these things, but also interesting enough for people who are. So pretty simple definitions. Shortness of breath would be difficulty in breathing or a dyspnea. And a surgical airway is essentially a procedure to open an airway between the lungs and the environment. And now, what we're going to talk about tonight is essentially when this is a life-saving procedure in what we call a cannot intubate, cannot ventilate situation. So those situations are patients who have an impending airway obstruction, patients who, for obvious reasons, as cannot intubate, cannot ventilate, cannot be intubated or ventilated. And when you do this procedure of a surgical airway, prophylactically, when you think that an airway will be a problem, and what are some cases of that? Patients who have large upper aerodigestive tumors, tumors of the head and neck, nose, throat, larynx, face, patients who have laryngeal injuries, patients who have inflammation of the upper airway, whether it's from infection or other, if there's massive airway bleeding or massive nasal bleeding sometimes, trauma to the head and neck, and bilateral vocal fold paralysis. And then sometimes you know you have a patient that needs surgery for whatever reason, and you know that due to their facial anatomy, they have some sort of syndrome, you're not going to be able to get a breathing tube in safely, and that would be kind of creating a surgical airway. Maybe you hope not emergently, you hope that you know that ahead of time. So without going through this slide in tremendous detail, surgical airways date back to the time of the Egyptian hieroglyphics, where you can find some hieroglyphics that show a sharp pointed object going into the lower neck region. And if you fast forward to the 19th century, the 20th century, where it was used to treat things like diphtheria and other infectious causes of airway obstruction, it was used for pulmonary toileting and suctioning for bulbar polio. And then in the 1940s and 50s, people discovered that this can actually be used to be hooked up to a breathing circuit. So doing a surgical airway somewhere in someone's neck, like a tracheostomy, it was primarily used initially for neurologic disorders, and then hooking them up to a ventilator. And this was proven to be effective and safe, and that's where we are today. So there are certain features in the way that a patient may present that will show you that there's an airway urgency. So visible distress, can't breathe, holding their neck, look like they're not breathing well. Stridor, which is noisy breathing. Stridor can be inspiratory, stridor can be expiratory, or stridor can be biphasic. So inspiratory stridor is the like, when you take a deep breath in, noisy breathing, it means there's some sort of obstruction at a certain level. Expiratory is the noise on the way out, and biphasic is in and out. So noisy breathing, no matter what they're doing. You might see massive bleeding out of the mouth, drooling, inability to tolerate their own secretions, neck swelling, visible injuries, such as in facial trauma or laryngeal or neck trauma. They may have a muffled voice or no voice, or you may just know that there's an urgency because this patient had head and neck radiation for cancer or a history of some sort of throat cancer, and they're coming in with some problems. It may not be visible, but you think about, oh, this patient might need something a little more urgent. If they've had a prior intubation and a few weeks later they're having some issues, there may be some inflammation, swelling, or stenosis at that site. Exam, I mean, when it's urgent, and you really don't have that much time for an exam. But obviously a quick head and neck exam, half of it is going to be just looking at the patient and looking at their head and neck, really looking in their mouth in this case, and looking at their neck. Laryngoscopy, which is taking a camera, putting it through the nose and down to look at their vocal cords. I'm going to show you a picture in a minute. That may or may not be able to be done in an emergency situation. And the same thing for imaging, whether that's a CAT scan or an X-ray. Sometimes you may have to wait until patient's a little more stable. So these are pictures of the larynx. For those of you who do any intubations, this is actually a flipped view. This is the view that you get when you're looking at someone with a flexible scope, such as I do in the office. When I'm doing surgery, I also look at it in a flipped view. And basically the larynx is this cartilage framework, which is composed of the thyroid cartilage, the epiglottis, which you see here, the arytenoids. I don't know if my arrow is pointing to anything, but the arytenoids, which are in the back, these are the AE folds, the false cords, and these nice white pearly things are the vocal cords. And they open and close. When you take a deep breath in, they open so the air gets in, they close when the air gets out. And any derangement in this area is going to be, in all the various locations here, is going to be a reason that you can't put a breathing tube straight in here, which is the way people are normally intubated, and you have to get to here through, in this case, the neck. This is just a cross-section view, looking from the side as if you cut a slice and someone cut a slice down this way and look from that way. And you see that the blue, the green, the purple, and then the orange, these are all the pathways you have to traverse to intubate someone, whether you're putting a breathing tube through someone's nose, so nasal tracheal intubation, or oral tracheal intubation. And, similarly, any obstruction here, they can have a totally normal larynx, but they have a huge tumor here, or they're having massive bleeding from their tongue or whatever it is, you may not be able to pass a tube. So this is when you think of emergency airways. So I think the most important thing, and this is like a concept across medicine, is this is not just like a limited to one specialty problem. The airway is shared. I would say primarily it's shared by ENT, anesthesia, emergency medicine, trauma surgery. Of course, there are other people who are going to establish airways in different situations. There are pediatric surgeons who do air, but that's essentially who it is. And a lot of times, all of those specialties are going to be involved when you have an emergency situation. It depends where it is. It depends what's going on. But, that's who you're going to call on. And everyone brings different expertise and experience to the table. So, if everything is going the way it's planned in an emergency, your hope is to be able to just get your standard endotracheal intubation, which is taking a blade, putting it in the mouth, exposing the larynx, putting a breathing tube down. Sometimes you have to do a nasotracheal intubation. Sometimes you need to augment your visualization using different scopes, camera scopes. A glide scope is something maybe people are familiar with. Sometimes you may need to just mask the airway. So it's basically putting something like an LMA or a breathing tube that just has a mask over the airway just to oxygenate and ventilate. A lot of times in emergency situations that involve laryngeal swelling, that's actually not the best thing. And even in just your general situation, 3% of all intubations are going to be considered difficult. So everyone involved in securing an airway always has to have plan A, B, C, D, etc., and be ready to move from one to the other in quick situations. Same thing with communication. Anyone who's been involved in any emergency really knows that oftentimes things are like pandemonium and you have to just communicate effectively and be prepared. I know that Ksenia is also an ENT, and probably when she was a resident as well, we always carried around these little packs with all these different emergency things, including a scalpel for emergency airways, probably a tracheostomy, and some other fun tools to use in emergency situations. So the first thing I'm going to talk about is a tracheotomy or tracheostomy. Those are used interchangeably, but the bottom line is that is a hole in the neck. And you see here, this is a hole created between the tracheal rings. This is a tracheostomy tube and flange that's placed in someone's neck, hooked up to a circuit. So this patient is being ventilated here, surgical drapes. And tracheostomies don't need to be permanent. So especially if they're related to some of the situations we're going to talk about, once the patient's recovered, they can come out, the hole can be covered, it can close. Obviously, there are criteria for that, but it's not like the be all and end all that this patient is now doomed to have a hole in the neck for the rest of their life. What I will say is if you ever meet someone with a hole in their neck, you should know whether they had a tracheostomy or they had a laryngectomy. And that's important because I know people who've been in situations where they meet someone who they think has a tracheostomy. For whatever reason, they can't get a tube back in here in an emergency situation. They try to get a tube from above, and that patient actually had a laryngectomy. Their whole larynx is taken out and they have nothing when you go from above. And that can actually take an urgent situation and make it an emergency. There are different types of tracheostomies. I guess what we're talking about here is probably in this talk is the first two. One is a slash trach or an emergency trach. This is basically in that pandemonium situation, you're called, or let's say I'm called to see someone who's in distress. You're not in an OR, you're not in a controlled setting. The patient is freaking out, everyone's freaking out, and you're basically slashing their airway, getting something in to ventilate them and then stabilizing the situation. We also are not infrequently called to do urgent or awake trachs in patients who are a little more stable, but need an airway that can't be established from above. And then at least oftentimes you have the luxury of bringing them to an operating room, numbing up their neck, letting them be a little more comfortable. Maybe they can't lay flat because of whatever process is going on, but you can have them monitored, sitting up a little bit, numb their neck, do the procedure, put them to sleep once you're finishing up. An elective tracheostomy is, what we do on patients in the hospital who are already intubated or had prolonged intubation. And then there's a percutaneous trach, which is similar criteria as an elective trach. That's usually in someone that has to be in someone who's already intubated. I'm just going to backtrack for a second. These procedures, again, they're always going to involve communication, especially if you're doing these second two. You want to make sure that, your situation is safe. You have all the instruments available. Everyone on the team knows their role, who's handling what instruments, things like that. And there are complications from a tracheostomy. You can have a hemorrhage. You're cutting through the neck. If you're doing it in the slash setting, oftentimes you want to try to avoid major blood vessels. In that case, oftentimes it's done as a vertical incision instead of a horizontal, but you can have bleeding, you can get a pneumothorax, subcutaneous emphysema. Later, you can get pressure-related injuries such as granuloma, stenosis, or fistula. So this is not, without issue. And again, these can be reversible. The next one is a cricotheratomy, which I'll say I probably have never had to do this. I think, and I think I spelled it wrong up here, so my apologies. I've never had to do this because I usually go straight for the trachea, but there are cric kits and they're always found in the ER and found in the OR for anesthesiologists. And this is really the quickest way to get to the airway, which is making a puncture in the cricothyroid membrane, which sits between the thyroid cartilage, that's the Adam's apple, and the cricoid membrane. It's much easier to palpate. There's a small membrane here. You either with a needle, depending on the patient's age or depending on the situation, pop through, get air bubbles, and then put some sort of cannula and hook them up to a vent or put an actual trach in. But this is temporizing. It is the ATLS emergency situation protocol, but this has a high rate of complications and needs to be converted to a tracheostomy within 72 hours. The reason for the complication is that the location of this is right at the level of the larynx or right below the vocal cords. And you can get a lot of subglottic stenosis, which is swelling there. And then I'm not going to go into detail about this, but this is surgical airways that as ENTs we do frequently. This is, maybe not in an actual like urgent situation, patient crashing or coding, but this is a bronchoscope, which basically you have a rigid instrument you're introducing. It can go all the way down the trachea and it's hooked up to your ventilation. Let's say you have a stenosis or a narrowing. This is a rigid instrument that can pop through it and ventilate. And this is a rigid laryngoscope. The patient here in this picture is suspended. So this is, let's say we were doing surgery for a polyp of the vocal cords or something like that. That's how once the breathing tube is in, you can establish an airway. But sometimes this is also the way without a breathing tube. This is the way to do your procedure, get your access, see what's needed to be done, pull out the polyp or whatever is obstructing, and then you can ventilate through that. So I'm going to talk first about some visible pathology. And again, each of these are entire lectures in their own right. So I'm really just going to breeze through some of the salient points of them and show some pictures. So the first one is going to be Ludwigs Angina. So Ludwigs Angina is a rapidly fatal and progressive infection of the floor mouth. 70% of the time it's due to some sort of dental infection. In children, it's often due just to a polymicrobial upper respiratory infection. And this has a very high mortality of airway obstruction. And this is really an emergency that I know, everyone who deals with airway ends up seeing these, a couple of times. So infection usually extends to the floor of mouth, down to the submandibular space, posteriorly, superiorly, and basically because the floor of mouth gets so swollen, it pushes the tongue up and back against the hypopharynx. And maybe you can intubate this patient through their nose, but oftentimes you have to trach them. So I would say in someone like this, you want to be, and there's no right answer. It's really the clinical situation. You kind of, like I said, have plan A, B, C, and D and have everything prepared. But in someone like this, you may say, okay, they're stable enough. We can try to get a breathing tube in through their nose with a fiber optic scope, or you have to do a tracheostomy, take them to the OR. This most likely needs to be drained anyway. This patient's going to be very uncomfortable, drooling, having, significant edema. They're going to need imaging after that, antibiotics. They're going to need to be cooled down, a lot of resuscitation and steroids. But usually these patients, once the infection resolved, again, you establish an emergency airway. They don't need to go home trached forever. This next one, hold on, I'm just going to move my, okay, I don't know how to do that. This next one is angioedema. So angioedema is a self-limited localized swelling of the skin and mucosal tissues, which results in extravasation of fluid into the interstitium because of the loss of vascular integrity. This can be in isolation, idiopathic, and can be associated with anaphylaxis, urticaria, and typically typically affects loose connective tissues such as the lips, the face, the mouth, the throat, the larynx, the uvula, extremities, and genitalia. Patients like this present, as you see here, often with visible, very significant, kind of scary looking swelling. They may be hoarse, they may have throat tightness, dysphagia, be uncomfortable, and there are different etiologies. Again, angioedema is an entire topic in and of itself, but this can be mast cell related, histaminergic, bradykinin mediated. So ACE inhibitors oftentimes is one of those triggers. And, someone gets angioedema, and make sure if they're on an ACE, you stop it. And obviously airway protection is a priority. I would say almost every patient, at least where I work, almost every patient that comes into the ER with angioedema gets an airway evaluation. You scope them, you make sure things aren't swollen. But most of the, at least in my experience, most of the time, you don't need to crash these patients. A lot of times they are stable. Again, I've been in situations where, this guy, you need to do something to help him sooner than later. So if you need to intubate or trach them, nasotracheal intubation sometimes will work. They need to be monitored. We give them steroids, antihistamine, Pepsid. If they're on an ACE inhibitor, you give them that. Acquired C1 deficiency is another etiology. So sometimes they need a purified C1 inhibitor. And here's another picture just of the different grades of how you're going to grade it if you see this in the line. So this is like that same picture, the vocal cords, pretty, a little bit of swelling here, but everything is decently visible. This is now 50% obstruction, 75%. This patient is getting some sort of emergency airway. This, I think seeing this picture, you probably can imagine what the patient looks like. The face of the patient in front of this looks like there's obviously some very significant mid-face trauma that required plates across the mandible and maxilla and, nasoorbital ethmoid fractures. This patient, due to distortion of anatomy, bleeding, very difficult to intubate them. Sometimes these trauma patients come and they need a trach before they have their facial fractures fixed. They may not be as much an extremis and as short of breath, more than you need to, intubate them to get their procedures done. The next thing I'm going to just quickly review, again, these are all topics in and of themselves, is internal pathology. So these are patients who, unless you scope them or take a look inside, you see them, they're uncomfortable, but you're not sure why. So these are just some pictures of head and neck tumors, or actually laryngeal supraglottic tumors. Maybe in this one, you're able to intubate them normally, pass a tube here. In these, they're a little more challenging. Sometimes you know that these patients are going to undergo chemotherapy, radiation, they're going to need significant surgeries. You trach them anyway, just so that down the line, you have a stable airway. This is actually a picture of an intubation granuloma that's kind of massive and blocking the airway. And yes, an anesthesiologist looking here would say, no, if I, take a look, I can probably intubate them because I see, a pathway, and it's very possible. But again, you have someone like this, you have to be prepared A, B, C, and D. This is related to trauma from either prolonged intubation or some sort of other laryngeal trauma, and then some swelling, inflammation cause this development of granuloma, which is inflammation. You cut it out, and usually these patients are fine. This is subglottic stenosis, which is narrowing of the airway, and we grade it according to the Cotton-Meyer grading scale, grade 1, 2, 3, 4. There are other grading scales as well, but basically it goes from less than 50% to total obstruction. Again, it's obvious why you might need a surgical airway in these cases. This is a picture of someone with bilateral vocal cord paralysis. So that means that when they take a deep breath in, their vocal cords don't open. And actually, because this is soft tissue, mucosal covering the layers of the vocal cord due to the Bernoulli effects, when they take a deep breath in, this kind of collapses even more. There are many different management schemes for patients like this, but again, a lot of times, especially when you see them initially, you're going to need to secure an airway, and these patients will get trached. This is a picture. These are some pictures of epiglottitis, which we all know is much less common, at least in kids, due to, over the past, I don't know how many years the Haemophilus influenza vaccine has been around, but enough that we really don't see this. Now, I would say supraglottitis is much more of a disease in adults, where it's usually from nasopharyngeal and oropharyngeal pathogens. And these patients are going to be really uncomfortable. They're going to be sick. They're going to, whether it's epiglottitis, supraglottitis, they're going to be sick, fever, stridor, retractions, labored breathing, anxious. These are patients who might be that tripod or sniffing, muffled or hot potato voice, and they'll have severe sore throat. But if you can look in the back of their mouth, it will look normal. I actually just saw someone like that, not this bad, but an adult with supraglottitis about a month and a half ago, totally normal exam. When you scope him, everything was like a lesser version of this, but thankfully he was stable.
Dr. Isseroff,
these are
Dr. Isseroff, I'm sorry to interrupt. Yeah. We're running a little over time, so we're gonna have to.
Okay, I think like 2 more slides and awesome. I'll be done. Okay, so basically these are, this is the classic training, everyone, like don't touch the patient or do anything to aggravate them until you know that you can safely secure their airway. So these are patients you're going to want to see if you can oxygenate them. If you can have the most experienced person try to intubate them in a controlled setting, but be prepared to do a trach. If you can't, then, emergency airway is the way to go. And then lastly, these are foreign bodies. Here's a safety pin stuck in a child's airway. They may come in significant distress. Here's a piece of plastic. And, again, without going into too much detail, different management schemes of whether you're able to safely take this out without making the situation worse, or you need to secure an airway. And lastly, laryngeal trauma goes without saying. Patients with fractures, bleeding, swelling in their airway do need a secured airway. So I would say real life experience is definitely what prepares you. There's a lot of, at least in our training, they try to do a lot of practice. We have, now I was just reading this weekend, there's now they're making simulation games for ENT residents. They run otolaryngology boot camps when we're doing internship, but, obviously you have to always be prepared for whatever scenario, but since you can't be prepared, you just have to know your different algorithms and, different options that you have for securing an airway to take best care of your patient. So thank you so much for having me speak tonight. These are some resources, and I'll stop sharing my screen.
Okay, thank you, Dr. Isseroff, for a very interesting talk. I can tell you, as a surgeon, from our perspective, we sort of like check our phones until everybody up there is done doing whatever they have to do and then move on with that part of the procedure. But obviously it's very complicated and often very challenging to secure proper airway in patients that come in all kinds of situations. I just want to say also one thing, the simulation thing that you have, it seems to be in a lot of different residencies. We're getting more into simulations. OB also has a hemorrhaging dummy. So, there's all kinds of these practice things that hopefully are enhancing residents' trainings at this point. I'm going to move on to our next speaker, Dr. Esther Hirschhorn. is our next wonderful speaker. She's going to be talking about OB topics. Dr. Esther Hirschhorn obtained her bachelor's degree from Yeshiva University Eastern College for Women. Woohoo! She then attended Albert Einstein College of Medicine, and she received her MD degree and was inducted into the AOA Medical Honor Society. At graduation, she was chosen as a 2016 recipient of Excellence in Obstetrics and Gynecology and Women's Health Award by the OBGYN faculty at Albert Einstein College of Medicine and Montefiore Medical Center. She completed residency in obstetrics and gynecology at North Shore University Hospital and Long Island Jewish Medical Center. In 2019, she was awarded the Society for Academic Generalist Resident Faculty Award that was chosen by the North Shore University Hospital and LIJ OBGYN faculty in recognition of her academic accomplishments. She is now a board-certified OBGYN, seeing patients in private practice known as Women for Women OBGYN, affiliated with LIJ Medical Center. Without further ado, Dr. Esther Hirschhorn.
Okay, hello everybody. The topic that I'm going to be talking about today is bleeding in pregnancy. And because, oh, 1 second, it's not letting me. You guys see my screen, correct? Just won't. Oh, I guess I have to click it to advance. You know, when I chose this topic, I felt like this was a good analogy for what I was trying to do. I'm taking a humongous topic, just like Dr. Isseroff just did, and trying to compress it into a 15-minute talk. But what I figured I would try to do is pick something that is very common for many non-gynecologists that they would see. If anybody has friends, family, or they're a primary care doctor, an emergency room doctor, or any type of doctor really, they'll probably get a question at some point about first trimester bleeding. So I figured I'd talk about identifying the most common causes of first trimester bleeding and identify when first trimester bleeding becomes an emergent surgical intervention. So as an introduction, vaginal bleeding is very common in the first trimester of pregnancy. We define that as up to 13 weeks and 6 days of gestation. 20% of pregnancies are actually going to experience some sort of bleeding in the first trimester. And I often tell this to my patients when they come in because they're always nervous and upset and anxious. And so I try and reassure them that about 20% of pregnancies are actually going to experience some sort of bleeding at some point. This bleeding can be any combination of light or heavy, painless, painful. And whether it's going to be urgent or emergent is going to be based a lot on the etiology of the bleeding, what's causing the bleeding, and the quantity of the bleeding. So to go through the 5 most common causes of non-traumatic early pregnancy bleeding, the way I like to think about anything in medicine is systematically. I like to go step by step. It keeps you organized and concise. It keeps you thinking about things in an organized fashion. So I like to start vaginal or cervical. So I tell, you know, I start with the exam in the office, looking vaginally and cervically. Is there any vaginal infection? Is there any vaginal laceration that occurred? Is there any cervical polyp? A cervical polyp is an overgrowth of tissue on the cervix. It's similar to a skin tag that can occur on the skin. Similarly, a cervix can have an overgrowth of tissue and can create a cervical polyp. And in pregnancy, everything is a lot more vascular. Everything has a lot more blood flow. And so all these things, if they get irritated at all, can bleed. Next is implantation of the pregnancy. And this is a very, very common cause of early pregnancy bleeding. It is basically bleeding that occurs around the time of the last menstrual period. Often patients will say, I thought I was getting my period, I was having some spotting, and then all of a sudden, you know, the period never came. I did a pregnancy test and it was positive. This is really just, the way I explain it to patients is it's really just the pregnancy implanting itself, creating real estate for itself within the uterus. It needs to immediately implant itself and immediately create for itself a network that's going to be there for the next 9 months, that's going to help it succeed for the next 9 months. And so therefore it recruits a very strong network of blood and blood vessels, which I'm going to show in a couple of moments. And therefore, sometimes a little bit of bleeding can occur at the time of implantation. This is in no way urgent. This is in no way emergent. And it often just requires a lot of reassurance. Next is what we call threatened abortion, which is a very big kind of overall umbrella term that we use for any vaginal bleeding in the evidence of fetal viability. So this is a pregnancy that we pretty much confirms is in the uterus, is likely healthy within the uterus, but the patient has some vaginal bleeding anyways. The way that I try to describe this to patients, and I'll show a little bit in a little better way of how I explain it. But similarly to how I spoke about the implantation of the pregnancy, when the pregnancy is implanting, we have something called a maternal fetal interface, a place where the pregnancy interacts with the maternal, the lining of the uterus, the maternal portion of the uterus. And often when this, when the pregnancy and early pregnancy is implanting itself and establishing itself, there can be some bleeding from there. And I'm going to show in a moment what I'm talking about. The last 2 I bolded because these are the two of the most common causes of early pregnancy bleeding that can lead to surgical emergencies: early pregnancy loss and ectopic, and we'll get to those in a moment. So this is a picture of the maternal fetal interface. This is the fetal side, I'm sorry, and this is the maternal side, I'm sorry, and this is the fetal side. So on the maternal side, the way the pregnancy establishes itself is it starts with a big arcuate artery in the muscle of the uterus, and then it branches off into smaller and smaller arteries that open up into big open sinus spaces, and they basically just bathe the pregnancy. They bathe the fetal side of the pregnancy with lots and lots of blood. So these are open blood vessels at the end of this complex network. On the fetal side, everybody's familiar with this, the umbilical cord, and again, it also creates a complex network of blood vessels that kind of invade into these sinuses and kind of just establish themselves in this bath of blood. And you can imagine that, you know, at any point, any of this large amount of blood can lead to a little bit of bleeding at some point in early pregnancy. The way I thought best to explain this is actually from something that I discovered this summer. My 7-year-old decided that he wanted a water balloon party for his 7th birthday, and there was no way I was going to fill up 150 water balloons for his birthday party. And somebody showed me this bunch of balloons invention, which I think is genius. And I think it's actually a great, very simplified, but great analogy to the maternal side of the maternal fetal interface. So the hose is like that arcuate artery that we spoke about, and very simplified, it branches off into these tiny little smaller and smaller arteries that bathe into these big balloon sinuses. And you can imagine that the fetal side then invades itself into these balloons, and kind of these balloons bathe the fetal side of the placenta. And as you can imagine, if just one of these balloons, like kind of, you know, broke off for a moment, there was a little break in it, you know, that end would still be open and blood would come out of it. But it wouldn't be in any way impacting the majority of the pregnancy, which is still there and healthy. And often that's what causes a threatened abortion. Often it's termed subchorionic hematoma. That's a term that we often, patients often come in, you know, saying, oh, I was early pregnant, I went to the emergency room and I was diagnosed with a subchorionic hematoma. It's just small bleeding around the area where the pregnancy is implanting. So let's move on to early pregnancy loss. And this is a common occurrence occurring about 10 to 20% of all clinically recognized pregnancies. Essentially, I tell my patients 1 in 5 pregnancies end in early pregnancy loss. Just by simple criteria, early pregnancy loss is in no way an emergency. And it depends on kind of how it is diagnosed. Majority of the time, early pregnancy loss is either diagnosed in a routine exam in the office, or a patient has some vaginal spotting. They go to an emergency room, and there's found to be a fetal demise, that there's just no heartbeat in that little fetus that has developed. And there's 3 different ways that we can manage early pregnancy loss. There's expectant management, which is talking to the patient about allowing it to pass on its own. There's medical management, where we give them medication to help pass the pregnancy. And then there's surgical management, which in this particular case would not be in an emergent fashion. This would be offering the patient what we call dilation and curettage, or dilation and vacuum curettage, to help them facilitate removal of the pregnancy from the uterus. So what makes it an emergent surgical intervention? This is for patients that present with an early pregnancy loss with what we call hemorrhage. Now, hemorrhage is a catch-all term, I think, in medicine in general. There are strict definitions to hemorrhage, but the way I describe to my patients who either opt for expectant management or medical management, meaning they're planning to pass the pregnancy on their own, or patients that call with heavy bleeding from home that they think they're experiencing a pregnancy loss, I tell them that early pregnancy loss is going to be bleeding that is much greater than a period. This is not bleeding that they're used to. This is not bleeding that most doctors are actually used to. It is very, very heavy bleeding. They can pass clots the size of small golf balls, and that is all normal. What I tell them is it's supposed to be a crescendo. It should be like light bleeding at the beginning that escalates and escalates until it becomes, for a 2 to 4 hour period, a very heavy bleed. They could saturate more than a pad an hour for those 2 to 4 hours. But if that continues past the 2 to 4 hour period, or at any point they become lightheaded or dizzy, they need to come into the emergency room. And that's how I basically explain it to my patients. Oftentimes we get called from the emergency room for a patient that came in with heavy bleeding, and we have to quickly assess whether or not this patient has bleeding that is heavy enough to require an emergent intervention. Often the way we do that is based on hemodynamic instability, looking at their vital signs, their heart rate, their blood pressure, and just taking a kind of quick look at how heavy the bleeding actually is. And again, I think as an obstetrician and someone who sees this very often, we're more comfortable with the amount of bleeding that we see than maybe many other doctors are. But that just comes with experience with time. And then last is obviously signs of infection. So if someone comes in with a diagnosis of an early pregnancy loss and they have fevers, they have tenderness, there's foul smelling discharge, or any other sign that there is an infection inside the uterus, that requires an emergent surgical intervention to prevent obviously sepsis and further complications. The way I try to explain to my patients what might be going on in the case of hemorrhage, why does one pregnancy pass beautifully and the other does not, is another analogy that I like to use with my kids, stickers. Stickers, anybody that has kids knows that kids can put stickers in the most inopportune places. And if you find a sticker in a place and it's, there we go. And it super easily comes off. That's a beautiful thing. So if a pregnancy is in the uterus and it the whole thing sheds off like a beautiful, sticker that's stuck in the wrong place, that the uterus is able to react beautifully. It's able to clamp down like it's supposed to. And usually those people don't have any issues. However, when you find those stickers in the most inopportune places and you spend hours trying to rip off all that little residue, that's kind of similar to a pregnancy that doesn't pass completely. There's all these little kind of pieces of the pregnancy that are kind of left behind. And just like we talked about in that bunch of balloons analogy, some of those balloons are still functioning. Some of those balloons are still filling with blood, but others have open vessels at the end of it, and those open vessels are just pouring out blood. And what we have to do is go in and remove that residue of the sticker residue, in order to help that patient's uterus clamp down appropriately and to stop the bleeding. And so these patients will go for an emergent D&C to the OR. This is generally patients that are getting blood transfused on the way to the OR. Usually sometimes we have to give O-negative blood to these patients if they're bleeding super heavily, if they're hemodynamically unstable. And we take them to the OR for an emergent D&C. And majority of the time, that helps to stop the bleeding. Obviously, there can be further complications, which I won't go into here, but that is a surgical emergency. Last topic I'm going to talk about in the topic of first trimester bleeding is an ectopic pregnancy. So an ectopic pregnancy is a pregnancy that has implanted outside of the normal uterine cavity. The most common place for this to implant is in the fallopian tube. That's why I showed the schematic here. There's obviously other places it can implant, but this is the most common place. And again, another analogy, because I tend to use analogies for my patients, I find that it helps them to explain things, is what is an ectopic pregnancy? It's taking a little small red balloon and asking it to become Clifford, the big red balloon. The uterus is meant to grow to many, many times its size in pregnancy. It is a beautiful organ that is meant to hold a pregnancy, grow to many, many times its size, and then regress at the end of pregnancy. The fallopian tube is this little red balloon. It is not intended to do so. And so what happens in an ectopic pregnancy is that as the pregnancy grows, because it does not know that it is implanted in the little red balloon and not in Clifford, the big red balloon, is that as it begins to grow, it then ruptures the fallopian tube. And that's when an ectopic pregnancy becomes from an urgent evaluation to an emergent evaluation. I always take ectopic pregnancies extremely, extremely seriously. I always consider them urgent. The difference between urgent and emergent I'll talk about in a moment, but I have seen ectopic pregnancies that are waiting to go to the OR. We will put them on the OR schedule for whatever reason, the decision we have made that they needed a surgical intervention, and I've seen them within hours go from stable to unstable, go from not ruptured to ruptured. The fallopian tube is a very sensitive organ, and the pregnancy is very vascular, and if anything kind of disrupts that pregnancy, or if it ruptures, it can be very dangerous and cause internal bleeding within the patient and can rapidly become emergent. So what are the risk factors for ectopic pregnancy? This is a patient that has a history of ectopic pregnancy in the past. Any patient that has a history of damage to the fallopian tube, such as a patient with a history of a sexually transmitted disease, prior pelvic surgery. Very common is use of assisted reproductive technology, uses of IUI or IVF to get pregnant, a history of cigarette smoking, or a patient older than 35. And again, like I said, ectopic pregnancy is always urgent within the obstetric world. We always take it seriously, but the treatment, if it's not ruptured, can be either medical or surgical. Medical being a medication that we give patients with very strict instructions of when to return and what surveillance they will need in order to help resolve the pregnancy, and then surgical. So what makes an ectopic pregnancy an emergent surgical intervention? That's when, again, the patient, the first two go hand in hand, hemodynamic instability and ruptured ectopic pregnancy. Essentially, when that ectopic pregnancy ruptures, similar to that bunch of balloons we talked about before, all that vascular network that this pregnancy has established then goes flooding into the patient's abdominal cavity. There's internal bleeding, and the patient can become very unstable very quickly. And so these patients would require an emergent surgical intervention. Similarly, there's something called the relative contraindications, which essentially in medicine means it's not really a great idea not to do surgery, but patient factors can play a role. In certain presence of relative contraindications, we generally recommend that the patient go to the OR more emergently. Reason being, these are the types of patients that we have seen who progress to an unstable picture within a quick period of time. So these are patients who there's actually cardiac activity within the ectopic, meaning we can see see within the ectopic a little fetus with a heartbeat. Patients that have a very high initial pregnancy hormone concentration, ectopics that are measuring greater than 4 centimeters in size on ultrasound. And then lastly, it's just patients who would refuse to accept blood transfusions, obviously just because we wouldn't want to treat them conservatively and then God forbid they come back ruptured and then we can't give them the proper treatments. So again, that was a very quick overview of first trimester bleeding in a nutshell. I hope it was helpful. Thank you for listening to my presentation.
Dr. Hirschhorn, thank you very much for that wonderful presentation. Even for someone who did OB many, many, many moons ago, it's always great to have a refresher. We're going to go on to our next speaker. I think you have to stop sharing your screen now. There you go. Our next speaker is Dr. Shani Fruchter. Dr. Fruchter is a graduate of UCB University, Stern College. Oh, Stern graduates, it's amazing. She obtained her medical degree at Torrey College of Osteopathic Medicine, Harlem. Upon graduating, she pursued a career in surgery, completing her residency at Hackensack University Medical Center. Palisades, she completed her training with fellowships at Advent Health Orlando and NYU Langone Medical Center in hepatopancreatobiliary surgery, as well as abdominal transplant surgery. Dr. Fruchter is currently on faculty at NYU Medical Center in the Division of Acute Care Surgery, where she is an assistant professor. Without further ado, Dr. Shani Fruchter.
Good evening, and thank you for joining, everyone. First, I also want to thank Dr. Isseroff. As a emergency general surgeon, I have to respond to all the emergency surgical airway pages, and I always take a huge sigh of relief when your colleagues are there before me. Always a fear that I'll have to break someone or crack someone emergently on the floor. So I'm going to speak about abdominal surgical emergencies, and mainly focusing on when abdominal sepsis becomes a surgical emergency. If I can get my slides to move. There we go. So what constitutes a general surgery emergency? So essentially it's when you have sepsis and you have a need for source control, or if you have ischemia or impending ischemia of intra-abdominal organs. And so back to basics, how to identify it. We need a thorough but targeted history and physical exam. And one thing to focus on with abdominal pain is the timing. So is this chronic or is it acute? Generally, chronic pain is not going to become a surgical emergency, but if that pain changes or if there's sudden onset of pain, that's concerning. You also want to think about the location. Is it diffuse or is it localized? Diffuse pain can often just be gas or something a little bit more mild or less concerning, but focal pain is when it becomes concerning. That lets you know that there's one specific area that's causing a problem, so one specific organ. When it goes from focal to diffuse, that becomes a bit more concerning as well. And back to our sepsis criteria, right? So 2 out of 4, fever or hypothermia, tachycardia, tachypneic, leukopenic, or leukocytosis. And then as abdominal surgeons, we want to think about our associated GI symptoms as well. And so an acute abdomen is essentially peritonitis in the setting with the presence of either ischemia or sepsis. And so peritonitis is inflammation of the lining of the abdominal wall from a noxious stimulus. And so how do you want to be able to identify a surgical abdomen? So we'll go through some different diagnoses that are most commonly seen in general surgery and also different exams. So acute appendicitis, one of the most common diagnoses that we see, most common consults that we'll see. So typically, there's a generalized or periumbilical pain that migrates to the right lower quadrant, and different exams that you want to do here. So appendicitis should be a clinical exam. And a clinical diagnosis, you shouldn't need a CAT scan or ultrasound or other imaging to diagnose it, even though we always insist on it. And Most commonly, you see tenderness at McBurney's points. And McBurney's point is if you take you draw a diagonal line from the umbilicus to the ASIS, and it's 2/3 from the umbilicus and 1/3 from the ASIS. If you press down there, the patient will be tender, and most commonly they'll have rebound tenderness. So that's when you quickly let go. They're more tender when you let go than when you push in. Robsing sign is also you're palpating the left lower quadrant towards the right lower quadrant. And what you're doing is you're pushing this inflamed appendix up against the peritoneal lining of the abdominal wall, causing referred pain when you palpate on the left to the right lower quadrant. And then we have obturator sign and the psoas sign, which are two other less frequently done. Obturator sign, the patient's supine and you flex at the hip, and then you internally and externally rotate, and that brings the appendix up against the peritoneal lining of the abdomen. The psoas sign is for a retrocecal appendix. When it's sitting behind the cecum, you have the patients laying prone, and you're essentially extending the thigh to bring it in touch with the psoas muscle. Appendicitis is caused by an obstruction of the orifice, usually an appendiculitis, which is a piece of stool that becomes like a rock, or lymphoid hyperplasia. So that's most commonly seen in kids after a viral illness. There's a bimodal distribution. Most people think of it as a disease of children. We see it often in adults as well, most commonly over 60, but every age in between. And management is these patients need to be diagnosed pretty expeditiously. If not treated within 24 hours, they'll generally go on to proliferate. There's been multiple studies done in the last 10 years looking at treating appendicitis with antibiotics alone and not surgery. Most recently, the CODA trial was published. It was a multi-institutional trial looking at treating patients with antibiotics instead of surgery. So for the most part, patients will do better with surgery, but if they're a poor surgical candidate, you could attempt some medical management there. But again, you want to identify this within 24 hours. We have Alvarado score, which is also a clinical modality, but we look at different symptoms and lab values to determine how likely it is that the patient has appendicitis or not. And thank you, Dr. Hellman, for previously sharing this meme of McBurney's point. So next we'll move on to small bowel obstruction. So these patients present with nausea, vomiting, abdominal bloating, and obstipation. Most commonly, it's caused to adhesive disease from prior surgery. I had an attending who said that open surgery is a disease, so it causes more adhesions to form. Other etiologies would be hernias or masses causing obstructions. We see this throughout all different ages. And the surgical concern here is that an obstruction will cause decreased perfusion of the small bowel, which will then lead to necrosis and perforation. So if not identified quickly and treated, generally we'll treat it with bowel arrest and nasogastric decompression. So we want to suction out all the food that may be in the stomach and just all the gastric and pancreatic juices that are made each day. We make several liters of fluid in our GI tract a day, and so if it's not going forward, it's just going to sit there. And so we put a tube into the stomach to help suction this out and decrease the pressure on the system. If a small bowel obstruction is not identified or treated, then it will promote bacterial translocation from the bowel, which will cause sepsis. If the blood supply to the bowel is compromised at all, if the adhesions include the mesentery, then the bowel won't get the blood supply that it needs, which again will cause some bacterial translocation. And the bowel will start necrosing. It'll become ischemic, and ischemic bowel leaks and perforates, and then you get gut flora in the otherwise sterile peritoneal cavity, which causes severe sepsis and will lead to septic shock and death if not treated. Moving on to large bowel obstructions. So again, the patients present similarly, different etiologies. These are usually due to mass. So oftentimes patients will come in, they haven't had a bowel movement in a week, they're bloated, they're uncomfortable, and they generally have an undiagnosed colon cancer, whether it be completely obstructing or near obstructing. Other causes are hernias. So the sigmoid colon doesn't infrequently get stuck in the inguinal hernias, or a volvulus. So a volvulus is when the colon is big and floppy, and the descending and sigmoid colon is usually they have attachments to the lateral abdominal wall. So if those attachments aren't there, or if someone has lifelong constipation, there's larger volume of stool in the sigmoid colon, it gets stretched out and big, it'll kind of flop on itself. When it flops on itself, you get a twisting of the mesentery, which also impairs blood flow to the colon, and it also causes a kinking of the colon itself. The surgical concern with a large bowel obstruction as opposed to a small bowel obstruction is the inability to decompress. So the ileocecal valve sits between the small bowel and the large bowel, and it's a little muscle there, and it just serves to prevent reflux of colonic material back up into the small bowel. However, because of that, it also won't allow you to drain the colon proximally. And so when someone comes in with a large bowel obstruction, they have what we call a closed loop obstruction, that you can decompress them proximally or distally. And so you essentially get a balloon that continues to fill up with air, fill up and fill up and fill up to the point that it's going to perforate. So large bowel obstructions are an emergency, and they either go with GI to be stented if there is a malignant stenosis, or they'll go for general surgery. Depending on whether the patient's stable or not, we can do a formal resection, or sometimes we just have to do what's called a blowhole colostomy, where we bring up a loop of bowel, usually the transverse colon, up to the abdominal wall, and just open up and relieve the pressure. Very fun and gratifying operation. Moving along to biliary disease. So there's a wide range here, right? So gallstones can cause problems. About 20% of adult Americans will have gallstones. About 20% of them have some sort of symptoms. And the symptoms will range from biliary colic, which is postprandial pain, generally right upper quadrant epigastric. They'll be bloated, nauseated, and it's usually short lasting. It'll resolve usually within 30 to 60 minutes. If a stone gets impacted at the cystic duct orifice, then the gallbladder can't drain. And so you get a buildup of bile and oftentimes bacteria, and you get what's called acute cholecystitis. Now, this isn't a surgical emergency, but it is a surgical diagnosis that requires antibiotics and oftentimes surgery on presentation. When this progresses to be a surgical emergency is ascending cholangitis. So this is obstruction of the common bile duct. So oftentimes by choledocholitis, so a stone in the bile duct. And if this is not relieved, you get reflux of bacteria from the duodenum up into the bile ducts and then up into the intrahepatic bile ducts. And this could also be, a high degree of mortality within 12 to 24 hours if not treated. So, our sepsis guidelines, judicious fluids, antibiotics within an hour of identifying these patients, and then they need emergent decompression. Generally, this will be done by GI with an ERCP. If there's no GI available, then surgical decompression. Some eponyms for ascending cholangitis is the patients will present with Charcot's triad, which is right upper quadrant pain, fever, and jaundice. When this becomes more serious, it becomes Raynaud's pentad with the addition of altered mental status and septic shock. A little depiction here. Continuing on further down the abdomen is diverticulitis. So these patients, you can think about it as appendicitis of the left lower quadrant. They have similar pain, including cramping pain, they're bloated, and they'll oftentimes have diarrhea, sometimes fever. This is caused by increased intraluminal pressure of the colon wall. So if there's a higher load in the colon and it sits there, so there's stasis, then you get little outpouchings where the vasorecta come in. So that's the weakest point of the colon. And it's generally thought of as a disease of the Western diet. We have a low fiber diet, industrialization and refined sugars and refined flour. And so our stool has a lower weight and it just transits along slower. And so it sits in the colon, oftentimes the sigmoid colon, and it gets heavy and it sits there. And so you get a weakness, these little outpouchings in the weakness of the abdominal wall. And this is a diverticulum. So it has all three layers of the bowel wall part of it, and this is the inside look, and this is where this is the vasorecta, the blood vessels that supply the colon, or the colon wall rather. They come in here, and that's a point of weakness. And then this is an endoscopic location of the diverticuli, non-inflamed here. But if you get a little piece of stool or some bacteria that gets stuck in one of these diverticulum, then it'll get inflamed. And this could be managed if it's just a simple inflammation, managed without antibiotics and bowel rest, all the way up to a higher classification, which would become a surgical emergency. So we get a weakness here, and then with the inflammation, it makes it a little bit more, even weaker. And you can get necrosis and perforation through one of these diverticulum, and then you get seepage of bacteria and stool from, again, the gut into the peritoneal cavity, which is sterile. And then you get development of peritonitis. So here we have our healthy colon, here's some diverticulum, and then this is when it gets inflamed, and this could thin out, cause the perforation. Another depiction. And here we have our Hinchey classification. So the Hinchey classification is how we classify complicated diverticulitis. That's when there's a perforation. So Hinchey 1 is when there's a small contained pericolic or mesenteric abscess. So it's very localized, it's right near the colon, and then usually with some bowel rest and antibiotics, the colon will seal itself off. And similar here, the Hinchey's 2 was just, it's not quite so localized. Hinchey's 3 is when you get purulent peritonitis, so it's been going on for a little longer, the perforation hasn't sealed itself just yet, or the patient was home for a couple of days before seeking medical care, and so just went untreated a little bit longer. Hinchey's 1, 2, and 3 will usually resolve on their own with antibiotics and bowel rest. The Hinchey's 4 is what becomes a surgical emergency. These patients have fecal peritonitis. So either the hole is so large or it's been going on for so long that you have stool seepage throughout the belly. It's diffuse in the peritoneal cavity, and these patients come in, they come in sick, they're behind the 8 ball, you recognize the sick patient, they're in septic shock, they often have multi-organ system failure. These patients need quick IV fluids, antibiotics, and then a quick trip to the OR. Hernias also similar. There's a wide range. They range from reducible, where you're able to push it back in. Hernia is essentially a hole in the a defect in the fascia of the abdominal wall. And we have all different types and all different locations. They classify by what they do. So is it reducible? Are you able to push the abdominal contents back into the peritoneal cavity? Is it incarcerated, where it's just kind of chronically stuck there? So if a hernia is there for a long time and it's reducible, it's not, it's in, it's out, it's in and out, develops some inflammatory process around there, and so it just gets stuck. But it becomes an emergency when the hernia becomes strangulated. And essentially this is because it cuts off the blood supply. So surgeons were very simple. If there's any concern for ischemia, if there's any concern for infection, that's when we come in. So here we go. So we're concerned about the blood flow to the bowel. Oftentimes these patients are also, they're toxic appearing. on exam, they're in distress, they're uncomfortable, they're squirming in their bed. And the hernias, they're not reducible, they're firm, they're tense, they're very painful. And there's often skin changes. So there's erythema, there might be some ecchymoses, or even some thinning of the abdominal wall. In cirrhotics, they often get umbilical hernias. And there's not necessarily bowel or abdominal content in there, but they often have ascites. And just the chronic intra-abdominal pressure and fluid that they have, they'll get erosion of their skin. So when a patient with liver failure and ascites comes in with a big blue umbilicus, you get quite concerned, and that is surgical emergency there. And here are all our different locations. So we start off with umbilical. And then if you move north, you have your epigastric, usually up in the midline. Incisional could be anywhere where you had a previous incision. The fascia will only heal up to 80% of its strength, and so it's not uncommon to have incisional hernias. In the inguinal canal, we have direct and indirect, and we also have femoral, which is mostly seen or most commonly seen in elderly females, thin, frail women. The most common hernias that we see are inguinals, and indirect inguinal will be your most common of the groin hernias. It's just another depiction kind of showing here, this is most likely irreducible. It's not fully out. You have a little loop of bowel here. And then here's when it becomes palpable and visual on the, on the exam. And if your hernia neck, so if the defect itself is small, that becomes more painful and more concerning because you have this loop of bowel that's stuck out. And if there's a tight little ring around it, that's a higher risk of causing more ischemia or strangulation. And so, you're unable to reduce this hernia here. And after a few hours, it becomes edematous and decreased venous return. And then here it's becoming ischemia. You see it's turned purple. And that's usually some dead bowel there. So time equals bowel. And this is necrotic bowel. That was sitting in that hernia sac just a little bit too long. And then we get on to perforated ischias, which is what we don't want to hear when you're on call and your resident calls you that there's free air. That is generally scoop the patient up and get them to the OR. Free air means that the air came there's some hole in the GI tract that air was able to escape from the GI tract into the peritoneal cavity. And with air comes bacteria and succus and stool and all these things that are just gonna, sit in the belly and cause systemic sepsis and will lead to septic shock. And so what we need to do here is, again, source control, wash out the belly, and give some antibiotics. And depending, this could be anywhere in the GI tract. Most commonly, when you have a perforation without like a previous procedure or an otherwise, previously healthy patient, it's usually from a perforated peptic ulcer or from diverticulitis. Peptic ulcer disease was much more, were perforations from peptic ulcer disease going back to the PPI era was very common. It was the appendectomies of yesteryear, most common operations that general surgeons did. PPIs have greatly reduced that. However, you do have patients that have atypical reflux or GERD, and so those are often the patients that are untreated, so they'll present usually with epigastric pain. They have a history of some sort of gastritis or atypical GERD symptoms, and they have free air, or they're diffusely tender peritonitic, or the second most common location would be the sigmoid colon from a perforated diverticulitis that we discussed previously.
Dr. Fruchter, I think we need to start wrapping it up. I think you're at the end though, right?
Yeah, this is my last slide. That's free air, the lucency under the diaphragm, and then here on the cascade. I think that's all.
Thank you. Thank you, Dr. Fruchter, for that very interesting overview. I know it's very hard for all of our speakers to be able to condense their fields into the surgical emergencies, because as we know, everybody goes through years of training and there are tons of emergencies that we encounter on a fairly regular basis. So it's really hard to condense this material. So I really appreciate all the effort that everybody put into their talks. I don't see, so missing, I don't see any questions on the QA. So I am just going to make a few comments. You know, it's interesting, Dr. Fruchter, that you spoke about the treating appendicitis conservatively. Unfortunately, I think during the past year and a half, during COVID, that became the mainstay of care for appendicitis, as opposed to taking kids to the OR. And, you know, I've heard from my pediatric surgeon friends about, unfortunately, kids who came in with perforated appendixes because they couldn't go to the OR. They weren't deemed emergent enough to go to the OR during the pandemic. So, you know, we, you know, on some level, I think all of us were sort of exposed to how we try to minimize some of these emergencies, or how to try to treat them more conservatively than maybe we would have otherwise during these times. I, you know, as a surgeon, as a GYN oncologist, I have to say surgery to me is the most fun field of medicine by far. I don't think you can compare it almost to any other field of medicine. We have a lot of fun in the OR. It's interesting. And it's gratifying. It's instant gratification. You get to do surgery, you get to see the patient get better. And there's a lot to be said about that. Unless there's any further questions from the audience or any other comments from any of the speakers or the panelists, I'll give a minute. Okay, well, thank you. I hope everybody found this an interesting talk. And once again, a huge thanks to Dr. Aaron for putting this all together as our first talk from the surgeons to our JOWMA audience, and hopefully more to come. Have a good night, everybody.